connection. Yeah. So how are they messed up? Oh, there we go. Good afternoon, everybody. This is Dr. Dana Harganani, Chief Medical Officer for the Oregon Health Authority. I am joined here today by my colleagues for our Tuesday webinar series. We have Dr. Tom Jean, who's the Deputy Public Health Officer and Deputy Epidemiologist for the state, as well as Dr. Ariel Smith, who's the Medical Director in her normal day job for the Health Evidence Review Commission and helping on our COVID response. We are now into our May series. We have committed to continuing these through this month and hope that we can continue to provide valuable information to you as we continue our COVID response. I will just remind everybody that due to our structure on Tuesdays, we are unable to answer questions real time, but we would encourage you to put your questions in the chat box, which we collect at the end of this and help to construct our future webinar series and information that we'll bring back to you. So today we are going to talk again, as usual, about our EPI updates on what we're seeing related to COVID-19 in our state. We're going to dive into further details regarding our surveillance strategies and quarantine recommendations. I will also be providing more detailed information about reopening of or restarting of elective surgeries. We will briefly talk to you about OHSU's Key to Oregon study that we are supporting them on. And then we will land this presentation today with a variety of questions that you've sent to us and do our best to respond to them. So first, we'll just talk about the current status of COVID in our state. Here are the normal testing result slide information that we usually share with you. This is as of yesterday. We had 2,745 positive COVID cases based on our testing results. We have, unfortunately, 109 deaths in our state at this time. And we've had a total of 60,698 negative tests. And as I believe Dr. Jean will be sharing further information on, of course, these test results still do not reflect the full impact of COVID-19 as he discussed some of our other epidemiologic data. So with that, I'm going to pass this off to Dr. Jean.
Yeah, thanks. So this is the latest testing results from our weekly report with our weekly summaries. So this shows our cumulative test positivity rate. And you can see there, the latest week of data we have, our percent positive rate has dropped considerably to 3.2%, where it had been hanging out in the 4 to 5% range. And we also have a significantly increased number of total results, total tests, done last week as well. So over 12,000 up from 9,000-ish. So this reflects greater testing. We have a similar, if you look at the number of positive cases, a similar number of cases, a little bit down from the peak, 402 last week. So generally consistent with greater testing, and the reductions we're seeing in our other numbers of reducing overall prevalence. Here's a familiar epi curve. A little bit up and down here, but general still consistent downward trend from late March, including declines in hospitalizations with the blue lines there. Next slide. And then again, this is another familiar chart to everybody here. We've been showing this every week, but this is our daily ED visits. And you can see a big drop around mid-March and a gradual increase. And this is the total volume of all ED visits in the state. And maybe a little bit of blip down recently here, but fairly flat. In terms of COVID-like illness, as a percentage of ED visits, that's been nice and low for a few weeks now. And we recently, for the past few days, have been below 1% of all ED visits for COVID-like illness. So that is encouraging to see that. From our weekly report, here's the latest update on reported signs and symptoms for all cases. You can see the top 3 symptoms reported by cases are cough, muscle aches, and fever, with headache, shortness of breath, chills, not too far behind. And again, the gray bars here are representing cases that we're unable to collect that information on. So they don't, the blue and the orange don't necessarily total up to 100%. Back to you, Dana, please.
Sure. Another familiar set of data we've been tracking and sharing with you. This is looking at the number of COVID patients currently in our hospitals. The column on the far right looks at those patients who are known to be COVID positive based on testing. So across our Oregon hospitals, we have 90 known positive COVID-19 patients across our hospitals, 26 of whom are in an ICU and 15 of which are currently on a ventilator. In the next column to the left, those look at both patients who are known positives as well as suspected positives. And you can see the array of data there. Again, I'll just remind you this data has continued to lower or slow down. I recall with you before that the peak number of hospitalized COVID positive patients since we began capturing this data was just about a month ago, and it was a total of 156 known positive cases in our hospitals and 464 positive and suspected cases. So you can see here we are at a significant decrease since we started collecting this data a month ago.
So here are the latest projections for our modeling. As a reminder, we get an updated modeling report from the Institute for Disease Modeling every week, and we're also running the numbers ourselves to double check. So the latest projections are here, and this is showing kind of 3 different scenarios. But first I wanted to highlight the key messages are the prediction that we've got approximately, as of last week, approximately 9,200 cumulative infections to date in Oregon, of which only 2,300 had actually been diagnosed. So again, the aggressive interventions have been effective. This supports that in dramatically reducing transmission rates. And the data are consistent with a sustained 70% decrease in total transmission after the stay-at-home order on March 23rd. So what we're modeling here are 3 different scenarios. There's the blue and the orange and the green. So the green is the going back to measures that were in place prior to the stay-at-home order. And so that would be the 30% reduction, and that you can see that we would expect a large increase in new infections and the number of infectious if we went back to those measures. And those measures were no large gatherings, restaurants were takeout only, and schools were closed, so prior to the full stay-at-home order. And then the orange line is showing a change to a 60% reduction in transmission. And just to make those reductions a little more concrete, that 60% would be what we anticipate we will have going forward with our mitigation, our suppression strategies involving the widespread testing and contact tracing, which I'll talk about soon. So the next slide is actually just a zoomed in version showing the 70% contrasted with the 60% reduction. So it's zoomed in quite a bit here from the last one, but you can see how sensitive the model is to just a slight 10% change in the reduction, or 10 percentage point change in the transmission rate. Again, this is something we're looking at. These are the infections. And if you go to the next slide, we can see the hospitalizations. And so the titles of these are a little confusing, but the top is hospitalizations, the middle is ICU cases, and the bottom is cumulative death. Again, showing the 3 different scenarios with a steep increase that would happen with a 30% reduction. And then finally, a zoomed in version of that for hospitalizations and deaths, again showing that sensitivity to a slight change in our transmission reduction. So we're hoping for something close to that 60% as we start to reopen Oregon, and we want to make sure that we have the right workforce and measures in place to prevent any big spikes. We are anticipating a slight increase. All right, shifting gears to our slightly to our surveillance strategy. I talked about this last week a little bit. So just again, a reminder about our active surveillance strategy. The main components are expanding diagnostic testing, identifying and investigating all cases that we can, and tracing contacts for all cases. And then isolating and quarantine cases and contacts, in addition to providing wraparound support to help them maintain their isolation or quarantine. And then reducing transmission in the higher risk groups, including clusters that might happen in, for example, long-term care facilities and other congregate settings. And then the resource needs. So I'm going to go to the next slide, which is from one of our documents that came out on Friday with the governor's press conference. And this is kind of summarizing the testing and contact tracing strategy. So the high points are we need to test every Oregonian who is symptomatic with a fairly rapid turnaround. And we are now, as of Friday, our testing guidance includes a formal recommendation to test everyone who is symptomatic, assuming there's capacity in the lab that you're using. So the priority groups are still there, but now we're recommending as a second priority testing anybody with symptoms. Number two, testing asymptomatic individuals in group living situations. So we've clarified our guidance on this a bit too. It doesn't mean we're necessarily going to test everybody in these settings, but people who have known contact with a cluster in one of these settings would be including staff, would be a higher priority for testing. But in general, we're not recommending widespread screening of everybody who's without symptoms in a setting like this. And we have to have surge capacity to test large numbers, and we're definitely getting there. The next three are widespread voluntary sample testing, especially for the at-risk populations. So this will be a voluntary representative sample testing project that we've got going, and then of course there's the OHSU study and the Oregon State University study that we'll hear more about. We need to have accurate data for at-risk communities, especially tribal members and communities of color. Number four, active and timely contact tracing. So we need to have staffing to be able to cover every part of the state. Our goal is around 600 trained people who are culturally and linguistically representative of the populations they serve in their local areas. So we're making progress on this. We have both current OHA staff members and new hires and volunteers who will be helping with this. And I think we can provide an update of that in the future, but it's ramping up this month. And there's also proposed use of mobile apps to help facilitate contact identification. So stay tuned for more on that. Finally, centralized operations and coordination. So we down in Salem, we have our emergency coordination center, which is really the center of all the agency operations and statewide operations about COVID-19. And we have a new testing strategy manager there, and we have a unified coordination among all the labs in the state. So that's an overview of the testing and contact strategy. Okay, now in terms of our investigative guidelines at the public health level, we've, starting May 1st, added a presumptive case definition. CDC has requested this for all states. Although CDC calls it probable, we call it presumptive. I think we're the only state that calls it presumptive, and that's just because probable implies greater than 50% chance of being a case, and that's not always true for presumptive cases. So in any case, we'll be tracking them. So we've already started reporting these. Basically, a presumptive case is somebody who doesn't have a positive PCR test, but had close contact with a confirmed case. And then if they later do test positive, then they'll be recategorized as confirmed. So the local public health authorities investigate presumptive cases just like they would confirmed cases, and do the contact tracing and all that. And they are also asked to follow the same self-isolation protocol. Okay, I think we can move on. So finally, I wanted to talk about a couple of the highlights from our testing guidance. I mentioned this was updated on May 1st in coordination with the governor's announcements. So the main change here is that we are redefining symptoms consistent with COVID-19 to align with other states and CDC's definition that came out recently. So the new requirement is cough or shortness of breath or difficulty breathing, any one of those top three, or at least 2 of the following: fever, chills, repeated shaking with chills, muscle pain, headache, sore throat, or I got cut off, new loss of taste or smell. So that's our new definition. And we now recommend, as I said, that anybody with any symptoms from that list, meeting that criteria, can be tested for COVID-19, but again, should be a lower priority than the high-risk groups. And then the severity of symptoms and the available testing and healthcare system capacity should be factored into that decision. So it's not just is there a test available, it's whether you have PPE and staff and testing supplies to make it happen. And then finally, we added the following high priority groups. We've got quite a list going now of high priority groups for testing, and we have added to that migrant or seasonal farm workers. We added Pacific Islanders, and then we also added people from other linguistically diverse populations due to longstanding social and health inequities. So those are now on the priority list.
Dr. Jean, before we go on, I just have a brief clarification or clarifying question for you. You were discussing presumptive case definitions. Do those individuals considered presumptive have to have COVID-like symptoms to meet that definition requirement?
Right.
Yes. So both the symptoms of COVID-19, as you just described, as well as having close contact with a confirmed case, regardless of your test result. Great.
Right. Yeah. If they don't have symptoms, they would be a contact only. If they're in contact with symptoms, they'd be presumptive.
Great, thank you. I'm going to pass it over now to Dr. Smith, who's going to speak to our quarantine recommendations.
So this is in response to several questions that we had last week about quarantine, what do we recommend, what should we tell patients, etc. So the first question was, if we have a patient who has exposure to a known COVID case, how long should we recommend self-quarantine? And the answer is 14 days. And what do we mean by that? The patient should check their temperature twice a day. They should try to avoid any places where people gather, stay off public transportation, and contact their healthcare provider promptly. So, essentially staying at home and monitoring their own symptoms. Then the next question was, how long should a COVID positive patient who was asymptomatic and had a positive test, if that happens, what should we recommend? If the confirmed case is asymptomatic or just has maybe some mild symptoms, then we recommend isolating, staying away from everyone, including even household members, except for, as absolutely necessary, for 10 days after the collection date of the specimen that tested positive.
Great, thank you. And I just want to highlight that these questions we just responded to are regarding patients and exposure and self-quarantine. And there are separate guidance for healthcare worker exposures and how to manage that on our website. We can certainly bring that back at a future date if useful, but wanted to really acknowledge this is for more general public and your patients who might have questions about this.
Thanks for that clarification.
Great, we're going to move on now just to share a little more information about resuming elective procedures. So I brought some of this to you all last week, but we'll briefly review that about a week and a half ago, Governor Brown announced her plan for resuming non-emergency and elective procedures. That ultimately went into effect through the executive order that the governor issued last Monday, number 2020. And it's listed here, ultimately saying that Oregonians can begin to resume elective procedures as long as they are performed in compliance with OHA guidance. And so last week, I believe all work guidance documents were completed and posted as of Friday morning for resuming procedures within 4 different settings. So there's a separate guidance for hospitals, one for ambulatory surgical centers, one for veterinary facilities, and another broadly speaking for medical, dental, and other healthcare offices. And just to remind you, the original executive order 2010 that the governor had issued back about 6 weeks ago, the purpose of that was specifically to try to conserve PPE and hospital capacity as we were preparing to face what we thought could be a significant surge impact to our hospitals and healthcare system regarding COVID-19 patients. And now, as we've shown through the epi curves and our hospitalization data, We are beyond that and want to be sure that necessary procedures that have been delayed can restart, as they certainly can have an impact on individuals' health if they're further delayed. So let's talk a little bit more about the guidance that OHA has issued for resuming these procedures. In general, all of the priorities that are encompassed in our guidance document really are outlined in these 5 bullet points here. Number 1 is to minimize the risk of transmission of the coronavirus to patients, healthcare workers, and others, and that in particular is highlighted through our requirements for PPE in our guidance document, as well as physical distancing and infection control. We also want to avoid further delays in healthcare, as I just shared. We want to be sure, though, that we are continuing to maintain adequate hospital capacity in case we had an increase in COVID-19 cases as we begin to reopen Oregon in the weeks ahead. And then finally, to minimize transfers to skilled nursing facilities and other long-term care facilities that are impacted and have significant vulnerability because of the setting types as well as the clients or patients who live there. And finally, we are focused on ensuring we can reduce the financial impact, in particular to Oregon's health system, which is critical for our response to COVID-19 ongoing. So I shared this slide last time. I'm going to keep the specifics of our guidance at a high level because they do look different for every facility or setting type. But in general, the requirements for beginning to resume these non-emergent and elective procedures include things like ensuring you have adequate hospital bed capacity in a region before moving forward with those procedures that take place in a hospital or ambulatory surgery center, ensuring across the board that these facilities have adequate PPE supplies and that those supplies are being used alongside recommendations set by the CDC and OHA. Also to ensure that we have adequate testing capacity before resuming these procedures, and that these environments or facilities continue to follow strict infection control and visitation policies, again, to reduce the transmission of SARS-CoV-2. There are separate criteria. Once procedures do resume, they must start slowly, and we have set some specific criteria for resuming at 50% the pre-COVID volume, specifically for hospitals and ambulatory surgical centers, at least to start. And for other settings, requiring that the volume maintain low enough to ensure physical distancing, for example, in waiting rooms and other office settings. We also specifically request, as we're starting slowly, that healthcare providers and facilities prioritize those procedures to go first based on their indication and urgency, and really ask people to consider and share decision-making with their patients whether or not it is the right time to proceed with an elective procedure, depending on if, for example, they're a high-risk patient who may still balance may be that they'll be better off to hold off an elective procedure, but that's really at an individual level decision based on their own set of factors. It's really important to know also there may still be people out there that are concerned to go into a healthcare setting if they don't feel like it's necessary. So we need to, again, make sure this is done in shared decision making with the patients. And finally, we're asking facilities to really consider limiting those procedures that are elective and require potentially scarce resources, things like transfusions or stay at a nursing facility afterwards, or some pharmaceuticals that we're monitoring in terms of scarcity potential in the future. So these are all detailed in the guidance documents. I've listed, again, our healthcare provider website here for coronavirus. And if you go under the tab listed for healthcare providers and clinical laboratories, you can find the set of all of the guidance documents. There's also a separate tab for veterinarians. If you're looking for that one, that's where you can find that on our healthcare provider website. We are working to get a frequently asked questions document out. We are hopefully in the final stages of completing that. We have been receiving a tremendous number of questions about what the criteria mean. And so we are working to try to get that out as soon as possible, perhaps as early as today. For now, I wanted to highlight a couple of questions that have come through that we plan to have in our FAQs. So the first question is, can healthcare clinics reopen now that Governor Brown has issued this executive order? And the response is that actually healthcare clinics were never required to close in Oregon according to the governor's executive orders. This executive order that I've been speaking to pertains only to resuming non-emergent and elective procedures that require PPE. For example, those procedures that required PPE prior to COVID-19. We know PPE is being used heavily and appropriately right now because of the concern of transmission in any patient interaction. But we're specifically talking about those procedures for the purposes of this guidance, those surgeries or perhaps in-office procedures that really always required PPE and that were elective. Those were the ones that were asked to stop, and now based on this new executive order can begin to resume if they meet the criteria I've just outlined. None of these executive orders explicitly, for example, required a healthcare clinic to close its doors or to stop doing patient care. And I know there's been a lot of questions about that. So hopefully the FAQ will make that more clear. I do want to be also clear here in the last bullet. There was a separate executive order 2012 that the governor issued that required specific businesses to close. And we will further outline this in the FAQ. There were some businesses, things like spas, esthetician practices, and others that were explicitly required to close. This is part of the broader governor's response to physical distancing across the state. Those are still required to stay closed under Executive Order 2012 until further information forthcoming from the governor. So again, I know this has been confusing, but we hope that the upcoming FAQ will help to clear this up. A couple other questions that have come up with regards to the guidance is this question: am I required to maintain a distance of at least 6 feet between staff and patients except during a procedure, or is that just a recommendation? This is pertaining to the elective procedure guidances, and we would say that this is a strong recommendation. We would ask that an office implements, to the extent possible, physical distancing measures within waiting rooms and other areas of the office at all times possible. We know that some of your direct patient care will require you to be closer than 6 feet with your patient and ask you to, of course, take the appropriate precautions to protect you and your patient during that time. Another example of a question we've received: how can I best limit the number of people in a waiting area? Some of the best practices that we've pulled together here includes, to the extent possible, have patients wait in their cars before entering the facility and then contact them when it's actually time for the procedure to come in. Again, these are all related to the guidance on resuming elective procedures. In advance, when you're scheduling the procedure and preparing for their visit, ask who they're bringing with them so you can plan for how many people might be in attendance with them or in a waiting room. And ideally, ask anyone waiting to take a patient home after procedure to wait outside the facility if at all possible and if appropriate, and then to call them in when the patient is ready to be picked up. And finally, another question we received, there are quite a few criteria related to PPE in the guidance document for resuming elective procedures. And this question asks, does homemade PPE count towards my supply of PPE that is required for resuming elective procedures and under that guidance? And the answer is no. Really, in order to be counted in our requirements for PPE, explicitly we ask for a certain amount of required PPE days on hand, depending on the type of facility. The PPE that we're asking about must be medical grade and meet the standards set by Oregon Occupational Safety and Health Administration, NIOSH, which is the National Institute for Occupational Safety and Health, and the US FDA. Under the FAQ, we will share more detail. There are certain circumstances where, of course, facial coverings can be used, but not for direct patient care, and it's not what we're counting towards the criteria for resuming or continuing elective procedures. And I'll just give this as one last example. We're receiving lots of questions about which things can be or not be continued. So one question, for example, from some providers, can I provide massage therapy? And the answer depends on the location and type of massage services to be provided. And again, I'll just remind you from my earlier response, we're talking, this guidance really specifically talks about procedures that previously required PPE even before COVID-19. But this specific answer depends, again, on the location and type of massage services to be provided. So all medical spas, facial spas, day spas, and non-medical massage therapy services were closed or canceled under the Executive Order 2012 that I just mentioned, and must remain closed or canceled until further notice from the governor's office. However, if medical massage therapy is provided in a setting not required to close under that executive order, it can be provided as long as we continue to meet all the requirements within office settings. So I am going to move us. Those hopefully were enough information to get you a sense of what we're talking about in resuming elective procedures and what those procedures are, and we hope to get that FAQ out as quickly as possible. Okay, we're going to change a focus here, and we're going to pass it back to Dr. Spitz to talk about OHSU's COVID study that we are partnering with them on.
Thank you. So this is just a high-level overview. I would recommend that anyone who's really interested in this study go to OHSU's website or other resources and get the details from them. This is a study called Key to Oregon that OHA is providing some resources for us. It's being run through OHSU. They plan on enrolling 100,000 participants who are randomly selected around the state, and over a 12-month period, they're going to do basically surveillance for all types of COVID-related things. They're going to send smart thermometers to track temperature to the participants and have self-reports of COVID symptoms. If a patient has a temperature or reports COVID-like symptoms, they're going to get sent a home test kit. Follow-ups will be done by OHA for contact tracing and treatment, etc. For about 10,000 participants randomly selected from the 100,000 total, they're going to randomly test for them at home, even if they're asymptomatic, just to get a sense of what the total possible prevalence of COVID disease is in the state. And the goals for this study are to, go ahead, next slide, are to gather data about the virus in Oregon to determine any relationships between the amount of disease being detected with different easings of physical distancing measures, etc. And they want, one of the other hopes would be to identify cases in early stages to help with contact tracing and isolation, to help control the disease, and to give us some early warnings of emerging hotspots that might be happening around the state. Again, if you want more information on this or have questions, I would refer you to the OHSU website.
Great, we're going to now turn over to some of the questions we've been receiving, and we'll start with some questions related to testing and surveillance. Dr. Jean.
Yeah, so looks like we've got a good bit of time, so I'm going to go through a bunch of the questions we received last time. I'm sorry we can't get to every question. So questions regarding testing and surveillance. There's a question about the results that we're reporting coming from just our lab, the Oregon State Public Health Lab, which is part of OHA, or do the commercial and hospital systems report the results to you? And the answer is all of them. So we get results mostly via electronic lab reporting from all of the above. And at this point, the great majority of results are coming from the clinical and commercial labs, not our state lab. Are positive antibody tests required to be reported now or possibly in the future? So yes, they must be reported by healthcare systems as well as by electronic lab reporting directly from the lab. So they are required to be reported. However, they're not part of our case definition. So an antibody positive test is going to be useful information for looking at population prevalence and potentially identifying some degree of immunity in people who are IgG positive. But it's not very useful for diagnosis. Even the IgM does not become positive for up to 10 days after symptom onset. So there's no real utility for diagnosis. Next question, will further interviewing and contact tracing be done on those with positive antibody tests? And the answer is no, kind of for the same reason. We don't have any way to identify when somebody was sick or transmitting just based on a positive antibody test, which could be weeks or months or longer after their exposure. Can a patient choosing to be tested for antibodies have their personal information remain anonymous other than the county in which they reside? So just to clarify how this works, that in general, lab results are shared only with the patient, the ordering provider, and public health, and no personally identifiable information would be shared. Those numbers do get included in case counts, for example, but it's totally de-identified. There's no way to identify an individual. What is the false positive and false negative rate of the tests? Well, this varies a lot. We've kind of covered this for some of the tests. At this point, there are more and more tests on the market, and tests that have met the FDA's emergency use authorization. So I couldn't hope to summarize all of those. In general, the PCR testing based on a respiratory swab, it should have at least 60% sensitivity and approaching over 80% sensitivity, and that depends on the test, and the studies have shown different things. It also depends on the site of specimen collection and the technique. The antibody tests that are coming out more and more, they are showing quite good sensitivity and specificity, usually in the 90% for both. However, that's compared to PCR, so there's no other gold standard we can compare to. Okay, so if an asymptomatic patient is positive, what would be the guidelines for contact investigation? My understanding is that contact investigation for symptomatic patients begins 48 hours prior to the onset of symptoms. That's true. So if somebody's asymptomatic, we would go back 48 hours prior to when the specimen that tested positive was collected. That's all we have to go on. Somebody was asking about news reports that over 50% of the cases or COVID deaths are from nursing homes in general. Is this true in Oregon? Yes, that is true in Oregon. If you look at our weekly report, we do have the number of deaths reported from long-term care facilities, and of course our total deaths. So you can do the math, but it is just over half the deaths. And that's not too surprising. These are very vulnerable populations of generally older people with chronic medical conditions that predispose them. They're also in a congregate setting, which can promote the spread. When are we going to start opening up, especially in Southern Oregon, where we have very little cases and access to testing, easy testing? So per the governor, some regions may start to reopen as early as May 15th, but there's no firm date on any of that yet. So I can't say any more at this time. Okay, and finally, is it yet known if the mutations are significant in trying to develop a vaccine, especially given that these mutations occurred within just a few months and a vaccine will take 18+ months? So we've talked about how this virus is actually quite stable, and that doesn't mean it doesn't have mutations. It mutates all the time, but they're tiny, generally insignificant mutations. And the virus is already, highly virulent, highly transmissible. So, it's not like a weak virus that could suddenly become much stronger. I mean, this virus is already extremely good at what it does. So that combined with its stability that we've seen and the stability of coronaviruses in general, I think makes this quite unlikely. However, in public health, we're not usually directly involved in vaccine development, and we're not immunologists or virologists here. So you might need to look to the primary literature for more detailed answers.
Great. We're going to now go through some questions that are a little more clinically oriented specifically, although these have a lot of overlap. So I'll pass it over to Dr. Smith.
The first question has tons of overlaps with one that Dr. Jean just answered about the false positives and false negatives. This goes directly into that. What's the sensitivity of the PCR testing? The Oxford Center for Evidence-Based Medicine, which I would direct you to their site. They have a great site where they have rapid reviews. They looked at this question specifically a few days ago. They only found one case series that gave them information that they could try to determine a sensitivity. It depends on the day, how likely a test is to be positive if the patient really is probably very suspiciously going to have COVID. Depends on the day after symptom onset and the severity of the symptoms. So later in the course of their illness and more severe symptoms, with a nasopharyngeal swab, you can get up to about 73% positive. But we don't really have any way of knowing exactly who is specifically positive, and they basically hemmed and hawed and said they really couldn't give us a sensitivity. So the answer to the question is they're sensitive, but maybe not as much as we would like it to be, and that's the best test we have, so keep using them. And then the next question, I think Dr. Jean did a much better answer than we did about death in nursing homes. We are working on doing some characteristics of patients who've died, looking at that in more detail, that hopefully will come in the future. And then there was a question about skin rashes and skin findings in COVID-19. There's been some really interesting case reports about chilblain-like lesions on toes in kids and young adults called COVID toe. It's an interesting observation, but it's not included in the CDC definition of the disease, and it's of unknown significance. And then there's been some other case reports of other rashes. Again, unknown what significance these have. Then there was a question about fecal transmissibility. We do know that GI complaints are a frequent COVID symptom. There have been some studies, mostly done in China, trying to do PCR studies on stool samples, and found 30 to 40% of stool samples in patients were had PCR positive COVID tests, but it's unclear whether the virus that was found in the feces is actually live and capable of causing disease, and there hasn't been any confirmed reports of virus spreading from feces to a person, although there's been a couple of case reports where that was conjectured as a possible means. But at this point, again, washing your hands frequently and all that other really good hygiene is the best way to go.
Great, thank you, Dr. Jean and Dr. Smith. We are gonna close out now. Thank you for joining us. A couple comments again, as usual, please visit our website. There is constantly updates being made to our guidance documents. We try to highlight those significant changes every week with you, but we invite you to visit the website. It also includes daily updates to our epidemiologic data and case counts, alongside other information.
And I just wanted to point out that on this website there is a direct link to these slides and all of our other Tuesday webinars. That was a question that came up several times from people who are on the webinar. So if you want to review these in the future, there's a whole archive and you're welcome to look through them.
Great. And of course, as usual, please feel free to email us your questions if you didn't get a chance to put them in the chat box. We know there's a lot of interest in forthcoming information, especially as it relates to reopening and the governor's plans on that. Right now, the first kind of initial phase to that is the reopening of elective procedures. We again hope to submit the FAQ to our website so it's available publicly as soon as possible. And further reopening information will be forthcoming from the governor's office fairly soon. So in the meantime, we hope you will join us again on Thursday for the Project Echo session hosted by OHSU, and we'll have Dr. Jen Vines from Multnomah County join us, as well as other content experts. So please join us again on Thursday, and then of course we'll see you again next week. Thank you, everyone.